I try to convince you that if you talk about genetic, it's not that it's that simple that you mix paternal and maternal information and come up with a mixture of it. Often it's in fact quite more complicated. And in the introduction, you heard that we are located in Germany, in the southern part of Germany. And what are we? We are not a research institute. We are a private company, actually, but we're working in the field of diagnostics. So what our goal is, to use the state-of-the-art technology we have today to identify at least the genetic cause of a disease. And so it's in this nice building, and if you're familiar with this technology, so they are quite state-of-the-art, and I think it's possible to offer the best diagnostic technique to a patient. And today I will talk about what you see on the left side, what we call panel diagnostic mainly, and exome diagnostic, which is the most modern technology we can do in genetic testings. However, I will not talk about the right techniques we also offer for special diseases. And back in my own history, when I was young in school, there was one theory in the textbook I had to learn, which is called the one gene, one enzyme hypothesis, from these two guys back in 1944 who worked on this mold. And 40 years later, it seems to be still true, and it was not a big step to come up with this theory, so that we have one gene, and when it's mutated, you have a given disorder. And I think we believed in this for more than 50 years, and within the last years it became clear that it's still true quite often. I will give you two examples right away, but the things are in fact more complicated. This is an example where this hypothesis is still true. If you have a patient, sorry, it's no neurological disorders, but I will talk to neurological disorders later on. But it's a well-known disease, which is called cystic fibrosis. And if you have a patient with cystic fibrosis, there's only one gene where a mutation can occur, which is a CFTR gene coding for a chloride channel. You can do sequencing by Sanger sequencing. This is a traditional way to test for a single gene, where you have this fluorescence sequence information, or you run special assays for most common mutations in a given population. But even if you have a single gene tested with this old approach to Sanger sequence a gene, you have, even in a single gene, you have limitation. This is a titin gene. It consists of more than 300 exons. And if you do, and a mutation in this gene leads to some muscle disorders, also to some cardiomyopathies. And if you test these genes by the traditional Sanger sequencing, it's expensive, it's time-consuming, it's difficult, so here you are already in the limitations. And moreover, what we know today, and even especially for many neurological disorders, is that we have heterogenic inheritance. That means that mutation in different genes leads to an equal or overlapping clinical phenotype. So actually you have no clear idea which gene you have to test. And here we need the new technology to come up with a diagnosis. One example, sorry again, no neurological disorder, retinitis pigmentosa leads to blindness, as you probably know. We have a huge bunch of genes where mutation cause retinitis pigmentosa. And in a traditional way, you will probably analyze the 2 or 3 most common genes, but the chance to find the mutation is rather low because there are so many genes involved in retinitis pigmentosa, and for the most genes, they are rare causes. You will probably never test them by a traditional approach. So in panel diagnostics, with the next generation sequencing, so in preparation for this meeting, I was asked not to go into too much technical detail, so I'm more focused on examples and to give you more an overview what these techniques can do. Panel diagnostic means that we have a group of clinical related disorders where we have a bunch of genes involved in this disorder group, and we test them in parallel by next generation sequencing. And this will be my first part to introduce you panel diagnostics. And as you can see, I have highlighted the neurological disorders in red. There are quite a huge number of genes or categories of disorders where we think that panel diagnostics or panel testing by next generation sequencing is a golden standard to actually find the causative mutation. And okay, we divide them in subpanels, meaning more related subgroups, depends on a clinical phenotype. So let's talk about epilepsy, which is our largest panel we offer. Actually, we have more than 300 genes. These genes are well known for epilepsy, or they are coming from some research publication. We are actually not sure how important they are. In fact, they really are. Nevertheless, we try to upgrade our panel every month, or every half a year, so it depends on our workload, to really be in time with our genes. And actually, we do it by some standards protocol. I don't want to go into much details. We reach a specificity for more than 99%. And we can do it in a diagnostic testing within 4 to 6 weeks. We all do it by ourselves. We have our own bioinformatic pipeline, so nothing is outside. And there's one term I have to tell you because it's important to understand the following parts, is the term coverage. If you talk about next generation sequencing, you will always come in contact with this term. Coverage means, and if you go to Wikipedia, I have adapted a little bit, means the number of sequence reads we obtain from patient, for example, at the given position in the genome. We're doing panel testing. We have the target regions, that's for example the 300 genes, and we have these, it's aligned, the reads are aligned here, and if you have high coverage, you have many reads given the information of this special part of the genome. And if you have a higher coverage, then you have a higher specificity and sensitivity. I will come to this later again. And now, as I told you, I want to show you mainly examples. And this is one example. It was a 14-year-old female, and as a newborn, first seizures, and also some sociomotoric development delay and spastic muscle tone. And finally, we were able to find a mutation. It was a recessive disorder, so we had to find 2 mutations in a gene. You have probably never heard of it, and the reason is that only one publication so far at that point we found in literature which described a patient with a mutation in this gene leading to epilepsy. So it's really important to really upgrade your gene list all the time so that you have really a chance to find a mutation in one of these rare genes. And so the looks in the next generation sequencing data, you have these kind of pictures, but it's more a technical thing. So using the take-home message from this is that large panels with a lot of genes allows the detection of variants in these rarely affected genes. But now, I think one important thing is what we have seen in the last years with this next generation sequencing. I will show you with this example. It was a 9-month female, so quite young, and during the first days of life starts with these seizures, and then in the age of 8 months in clusters, the seizures appear to be focally, and the psychomotoric development was mildly affected. Metabolic screening was negative, and what we actually found is mosaicism. And with the old technique, there's almost no way to detect these kind of genetic variants. What does mosaicism mean? It means that only a part of the cells really carry the mutation. So you really need a sensitive assay to find these mutations. Nevertheless, we know they are much more common than we thought in the past, and they are disease-causing. Because we have also tissue-specific differences. Namely, normally we test for DNA coming from the blood, and the tissue which is affected is the brain. We have actually no idea how the mosaicism is in the brain. Maybe this higher and leads finally to the disorder. If you maybe try to reconstruct this with the Sanger sequencing, and actually it's also seen with the traditional Sanger sequencing, but only if you know that here this is the red signal, that something has happened here, the chance is rather high that you had overseen this if you had started to sequence this gene by the old traditional Sanger sequencing method. So these high coverage, so we need a lot of reads to really calculate and really detect mosaicism. So that is really the high power of next generation sequencing. We can actually detect these kind of variants. Why it's so important to really cover a lot of things? Because if you look to, we actually analyzed more than 3,000 patients so far, only for epilepsy. And in most cases, the most patients we tested are rather young. So the physicians are really waiting for the genetic report, also for treatment decision. What is the solving rate? And I think this is rather good. So positive means it's absolutely without any doubt that we have found the cause for this epilepsy. It's 33%. Negative is 14%. And unclear, what does mean unclear? Is because we test so many rare genes. Often we came up with variants we think they are actually causative for the phenotype. However, we have no proof that it's true because we don't have the power to do functional tests or they are not published. But we can be sure that many of these unclear at least will have some impact on the phenotype of the patient. And if we look, for class 4 and 5 mutations, meaning these are mutations, so it's a classification we use in genetics. Class 5 means it's absolutely clear that it's pathogenic. Class 4 means it's likely pathogenic. And when we look into our panel data, we found class 4 and 5 in more than 130 genes. But if we extend this a few to class 3 variants, meaning uncertain significance, what you can see is that we found mutation in more than 300 genes. And meaning it is really important to have good coverage and to cover as many genes as possible. The next thing is, let's talk about Exome-Diagnostics. What does it mean? So we know today, after the Human Genome Project was finished, that we have around 23,000 genes in the genome coding for all our proteins. What is when we sequence all these genes? And actually, one term, the exome, and the E is missing, means all these more than 20,000 genes coding for proteins. And this is only 1.5% of the genome. The genomic information in our body is mainly called genomic desert. There are no genes coding for it, or they are intragenetic, or they are introns. They will have a function, I'm sure of it, but actually we have just a rather weak idea what they are meaning. So, but we know that if you test this 1.5% of the genetic information, you have the chance to find a genetic mutation or a mutation in about 80%. So it's a good deal to test for this information. However, it's quite difficult to do the data interpretation. If we sequence your exome or my exome or for the patient, we have thousands of genetic variants where we have no idea are the disease causing or what they are actually doing. And to go through this list, it's really a task you cannot do. You will spend months per patient. So we use a trick to really improve the solving rate, which we called Trio-Exome analysis, meaning that we also sequence the mother and the father of the patient. It's important that they need healthy. So when they have the same disease, it's become a little bit more difficult. So what does it mean? When the child, for example, is affected and the father and mother is healthy, so there must be a new mutation, or we are looking for autosomal recessive disorder, where one mutation is coming from the father while the other is coming from the mother. And by bioinformatic algorithms, we can really filter these mutations out of the whole bunch of information. And so the list really condensed, and then we can go to the function and what is known about. And with this Trio-Exome analysis, we really can increase our power of our analysis dramatically. This is a technique normally if you have a panel with high coverage. So exome has a lower coverage, so you will probably miss some mosaicisms. It's really powerful if you have no idea what your patient has, what the disorder of the patient is. For example, mental retardation, one of our major tasks we have to solve. This would be some syndromic phenotype where you have actually no idea. So this could be a powerful tool because it's also possible to identify new genes with this technology. Does it work? Has it an influence on therapy? I will give you a quite impressive example. This is Lila. Shows you at the age of 6 months. And what was at that point, they had bone marrow failure and a deep developmental defect. And it was clear from the beginning that there must be a genetic cause because he had a brother who died at the age of 7 months and had exactly the same symptoms. So the physician decided to do a bone marrow transplantation and said, okay, the survival chance would be approximately 50%. However, we did this Trio-Exome sequencing and came up with a defect in a vitamin B12 carrier protein. It was not possible to see it in metabolic screening because the blood values for vitamin B12 were normal. And we think, okay, when the carrier protein is affected by the mutation, is it possible to treat Lila with a high dosage of vitamin B12? And as you can see, it's in the age of 4 to 5 years. She develops normal, she is a healthy little girl, and I think that shows you that genetic testing can drive therapy. Okay, it's a good example. We have also other examples, but nevertheless, we think in the future we will have more therapy options coming from genetic testing. So how about genomes? In the last minutes, let's talk about a little bit genomes. Today, with the new technology, it's not difficult anymore to sequence the whole genome. Not only the 1.5% of the genome by exome sequencing. Does it make sense? Is there any diagnostic benefit by doing this? First of all, what is a disadvantage or advantage of doing a genome sequencing? In the panel testing, we always run with high coverage, really that we detect every low mosaicism and really cover all our target genes and regions so that we will probably never miss a mutation in the target region. Exome sequencing, because we have to sequence more than 20,000 genes, so the coverage is lower. However, we test every gene. In genome sequencing, we have an even lower coverage. However, we're covering all the genomic desert, all the intronic sequences, so we really cover almost everything. However, you have to deal with really with big data. That's a big problem. You need really high computer power to do all the analysis. Just to compare you the huge bunch of data you have to deal with. So if you in panel data, you sequence 1.6 megabases. Whole exome is much more. And if you do whole genome sequencing, here's our panel, here's our exome. The amount of data increased dramatically, and you have to run this through a bioinformatic pipeline to come up with at least some kind of answers. And that's a big disadvantage at that point, since we have no idea what all these intragenic regions really do or have to do with a patient's phenotype. Actually, we have no idea really to interpret this data. At that point, I think genome sequencing is not an option. However, there's some benefit. We can detect translocation, inversion, all these old cytogenetic aberrations or deletions. If we have the right algorithm, we can detect this out of genomic data, which is not so easy, or it's not possible doing this on a panel data or exome data. So to give you to compare all these techniques, so it always depends on your single case, which is the best approach. In a panel, you have really high coverage of all the genes you think or they are published or they are known to be causative for a group of disorders. So the chance to detect mosaicism is high. However, if you run a panel on epilepsy, you really only test more than 600 genes. When there's an unknown gene or so on, you will not see it. But it's rather, I think the price is rather good. Exome sequencing, you're really sequencing the whole the coding regions. So you have the chance by doing Trio-Exome sequencing really found de novo mutations or found mutations in new genes. So it could be for some research projects quite good. However, the coverage is lower, so the chance to detect mosaicisms is also lower. If you do genome sequencing, you have the complete genetic information. Maybe once in your life it can be stored, which is also not cheap. However, you can store it. And in the future, when we know more about all these, when we did in the world millions of genomes and we have more kind of idea what's going on there, we can reanalyze the data and maybe found the causative mutation in a patient in 5 years. Because now then we know what the genome actually is doing. Still, we have some quality issues, and of course it's quite expensive. I think in diagnostic it's not the first choice at the moment, but in the future I think it will be different. So, I come a little bit early, that doesn't matter, okay. What we think is that genetic is important for dealing with patients for treatment, because patient with symptoms, first of all, genetics is important for diagnosis, to give the patient or the patient's disease the right name. So then, and moreover, in the past, maybe genetics stops here. Today, we know, as I show you as a sample of this little girl, Lila, from the genetic, we understand more often the clinical phenotype. What is the cause of all the problems a patient is facing? And from this, if you are lucky, maybe you have an idea what could be a good therapy. And so we think it's every patient where you suspect a genetic disorder should get genetic testing before treatment. Another example is epilepsy. Often ion channels in the brain are mutated. And as you probably know much better than I do, is that many of the drugs you use to treat epilepsy are really going to these channels. And if a channel is mutated, a drug will probably not work. still you will have the side effects, and so you really spend sometimes a lot of money on a drug which will not work. So this leads to an idea what could be a good treatment in your patient, and if you have an effect where you think you have an effective drug in connection to a mutation, you can have probably less side effects, and if you avoid treatment with ineffective drugs, it will reduce the costs. So I come to the end. I try to convince you that genetics is important. That's in the top of my take-home messages is, yes, genetic is important. And with the new technology, next generation sequencing, we can analyze numerous genes in parallel. So really the chance to find a mutation is really good. And therefore the solving rate has improved dramatically by this technology. Panel testing should be used when you have a heterogeneous but distinct disease group, for example, epilepsy. And if you are more unclear what your patient is suffering, then the Trio-Exome sequencing could be a good approach. And we think that a good genetic diagnosis can be crucial for treatment decisions. And my last slide is that we are not driven by technology. I think the technology has to be driven by a human, and these are all my colleagues, and they all take part in this work, and really we always try to improve our diagnostic pipeline for the benefit of the patient. And this picture was taken for our last Christmas postcard, so that's why it's a star here. And thank you very much for your attention.